My name is Devaki Vasudeo. I work with an NGO based in Sambhajinagar, which is now formerly, it used to be called Aurangabad, now it's Sambhajinagar. And it's called Savitribai Phule Mahila Ekatma Samaj Mandal. And within the NGO, I work in the mental health project, which is called Project Arunodaya. And in today's presentation, I'm going to talk about my research paper, which is about the impact of community health workers, which we call Manas Mitras in our organization, on addiction recovery outcomes. Now, within our NGO, we have a group of people called Manas Mitras who are community health workers. Now, they are based, like the creation of Manas Mitras is based on the idea of task sharing, wherein people who are not specialists in any particular field can be trained as counselors, as people having medical expertise. And so that's what we based the Manas Mitra program on. And we have 30 Manas Mitras because we work in an area of 30 villages. So we have one Manas Mitra for each village. And the selection criteria for Manas Mitras is on the basis that they may have had a mental illness in the past, or they were a former addict and are now recovered. So they were chosen to be a Manas Mitra. Now, the objectives of this study were to statistically evaluate how the frequency of visits by the community mental health worker or the Manas Mitra are impact craving modulation of the substance use patterns, and also self-reported well-being by the patient. Now, the reason now a lot of literature regarding substance abuse, of course, in India, and also regarding task sharing models. So substance abuse, of course, there was a survey conducted by the Ministry of Social Justice and Empowerment. And in this study, they found that at least in 2019, the percentage of people who were addicted to alcohol was 14.6%, cannabis was 2.8%, and opioids such as heroin was 2.1%. Of course, this is not everyone reports or documents their substance abuse, but this is what they found. And some research that was conducted into psychiatrists found that the WHO minimum for psychiatrists is that there should be 3 psychiatrists per 100,000 people, at least in low and middle income countries. In countries that have a better, like the more developed countries have 6 psychiatrists per 100,000 people. But in India right now, we only have 0.75 psychiatrists per 100,000 people. So we have a great shortage of psychiatrists and people who work in the mental health field. So in such cases where there is a huge gap in services, there is a, task sharing models can be very effective, at least in low and middle income countries like India. Where you can train non-specialist community workers and in, say, counseling or certain psychological methods, and they can help to bridge that gap by being lay counselors in their communities. Now, there are certain gaps in the existing research. Like, for example, the reason we were motivated to conduct the study was because, first of all, the focus area of Maharashtra is not targeted. Our focus area was Maharashtra, was specifically villages in Aurangabad, Sambhajinagar. And so there wasn't much research done in these communities, and especially related to addiction and like recovery, abstinence, things like that. Then also the literature, our study focuses on the communities where our workers and the layperson counselors work in their respective communities. Most of the research largely focuses on hospitals and clinics where patients will come in to take treatment. Also, there are, of course, ASHA workers who work in a lot of villages, and these ASHA workers already have a lot of responsibilities. Sometimes they are asked to take on certain mental health counseling roles. But these are additional responsibilities, and our Manas Mitras focus only on mental health. So, and also, like, there is not much evidence, again, as I mentioned, regarding addiction. So things like recovery, what are the patterns of use in these people who are addicted to various substances, the psychological symptoms they experience, things like that. Then we move on to methodology and research design. So our total sample size was 470 adults, who are male adults. We did have some female adults who were addicts as well in our sample, but for this study, we decided to exclude them. The age range of the participants was between 20 to 60 years, and they had all been diagnosed with a substance use disorder. And the substances that they used mostly, of course, was alcohol. And then there was tobacco, like gutka, chewing, BD and cigarettes. There was also cannabis like ganja smoking. And there was also some prescription drug addiction. So data sampling was based on community. So we already do work in the community. So it was convenience-based sampling. And it was our field officers who did this monthly identifying and along with the Manas Mitras. And the interview was conducted on a face-to-face basis at the participant's home. And the key variables that we monitored was, of course, the independent variable was mental health worker visits, and the dependent variables were recent use of the addictive substance, the change in the patterns of craving, and the self-reported well-being, which is out here written as current status. And we used Pearson chi-square tests of independence and Spearman rank correlation to analyze our results, mostly because our data was categorical. Then we have within the sample, this is the addiction profile, like 83.4% of our sample was addicted to alcohol, 60.7% were addicted to tobacco and gutkha, and the rest is much lesser percentages. So our key statistical findings was that a greater number of visits by our community mental health workers to the participants' homes to analyze how they were doing and their general well-being. All of these visits by the community mental health workers, so greater number of visits were associated with a greater reduction in craving. Then reduced substance use was also reported. So a greater number of people reported that the more often they saw the community mental health worker, they had significantly lesser, like they also were indulging in lesser substance use when the more often they met the community health worker. And also the lesser the use of the addictive substance was associated with significantly better well-being. So abstinence was associated with better reported, self-reported well-being. So our conclusion is that the regular Manas Mitra visits were associated with reduced cravings, lower substance use, and improved well-being among our participants. So it shows the effectiveness of task sharing models, that even in areas which do not have much in the way of mental health aid, or there aren't many psychiatrists or mental health workers around, a layperson counselor like a Manas Mitra, like somebody, a community mental health worker can help that gap, bridge that gap. So our future directions for studies are, of course, none of our data is based on standardized psychological tests. We would definitely like to do that in the future, especially in regards to substance use, because there are many questionnaires like audit and PCAS which monitor that. We also would like to include more females in our study in the future, like also maybe examine the population of female addicts. It's also important for us to conduct longitudinal studies to assess how the participants are doing in a 6-month or 1-month period, and how their recovery is during that time. Are they being abstinent or not? And we also need to evaluate, like this was one intervention where the community mental health worker visited the homes of people who were addicted to a substance, but there are other things, like we could monitor psychological illnesses and specifically target home visits, follow-ups, etc. So these are our references, and thank you so much. If you have any questions, I would be more than happy to answer them.